Atrioventricular Block ECG. Classification of atrioventricular block. 1. First degree AV block, also called AV delay, all beats are conducted but with prolonged AV conduction time. 2. Second degree, also called partial, AV block, some impulses are blocked, and others are conducted. 3. Third degree, also called complete, AV block, all impulses are blocked. For survival, an escape rhythm should emerge, either junctional rhythm, with narrow QRS complexes unless there is aberration, or idioventricular rhythm, usually with wide QRS complexes. First degree AV block. First degree AV block is defined as PR interval greater than 200 millisecond, following a normally timed, non-premature, P wave. That is, each P wave is followed by QRS with a prolonged PR interval, as seen in this figure. Site of first degree AV block. 1. AV node is the commonest site and is highly suggested by any of the following: very long PR interval, greater than 300 millisecond, highly variable PR interval, and normal QRS duration. 2. His Purkinje system is suggested by wide QRS, that is, bundle branch block pattern. 3. A combination of delay within the AV node and the His Purkinje system must also be considered. 4. Intraatrial or interatrial conduction delay is not uncommon, as occurs in left or right atrial enlargement, Epstein's anomaly and endocardial cushion defects. Second degree AV block. Second degree AV block indicates intermittent failure of AV conduction. This term encompasses several conduction patterns. 1. Mobitz type 1 second degree, Wenckebach, AV block. 2. Mobitz type 2 second degree AV block. 3. 2:1, 2:1, second degree AV block. 4. High-grade second degree AV block. Type 1 second degree AV block. Mobitz type 1, or simply type 1, or Wenckebach, second degree AV block, is characterized by decremental AV conduction, which manifests in ECG as progressive prolongation of the AV conduction time, PR interval, before failure of an atrial impulse to conduct to the ventricles. The PR interval immediately after the non-conducted P wave returns to its baseline value and the sequence begins again. Each run is called a Wenckebach period, which consists of several cardiac cycles, heartbeats. The length of Wenckebach periods may be fixed, or may vary from time to time, that is, variable number of cycles within each period. This sequence of events creates groups of beats, group beating, separated by pauses. Features of typical Wenckebach periodicity. 1. Progressive prolongation of the PR interval, the conduction time between the proximal chamber, the atria, and the distal chamber, the ventricles, that is, the atrioventricular conduction time, but in a decreasing increment, until 1P is blocked, and the process is repeated. 2. The non-conducted P wave creates a pause between QRS complexes, which is less than the sum of RR intervals of any two consecutively conducted beats. 3. Group beating results from the pauses. 4. The PR interval after the pause is shorter than the PR interval just preceding the blocked cycle. 5. Progressive shortening of the RR interval, that is, the ventricular or the distal chamber CL, because of the decreasing increment in the PR intervals. To understand the typical Wenckebach features, let us assume a sinus rhythm with Wenckebach AV block with a sinus cycle length, CL, of 800 millisecond. The CL equals PR plus RP intervals. In this example, the PR interval in cycle 1 of the Wenckebach period is 200 millisecond, and the RP is then 600 millisecond. The PR increased in cycle 2 to 300 millisecond, then the RP is 500 millisecond. In cycle 3, the PR increased to 375, the RP is then 425 millisecond. In cycle 4, the PR is 425, and the RP will be 375 millisecond. In this sequence you can appreciate the following. Gradual prolongation of the PR interval, the amount of increment is 100 millisecond between beats 1 and 2, 75 millisecond between 2 and 3, and 50 millisecond between 3 and 4. This is referred to as decreasing increment, indicating that although there is an increment in the PR interval from one beat to the other, yet the amount of increment is less and less, 100 then 75 then 50 millisecond. The greatest increment, the jump, clearly occurs between the first and the second beats of the Wenckebach period. The total sinus CL, PR and RP, is not, however, affected, 800 millisecond all through. Calculating the RR interval reveals a jump of 100 millisecond from 1 to 2 to reach 900 millisecond, which then gradually decreases to 875, 850, etc. This is usually described as gradual shortening of the RR interval, which could be a misnomer. To be more precise, it is an initial jump followed by gradual return towards its baseline. This phenomenon is obviously due to the decreasing increment in the PR interval just described. This figure demonstrates the typical Wenckebach periodicity, decremental conduction, manifested as gradual prolongation of PR, but with decreasing increment, until one P wave is blocked, pauses, each one being less than the sum of RR intervals of any two consecutively conducted beats, group beating. The PR after the pause is shorter than the PR just preceding the blocked cycle, and progressive shortening of RR. It is important to recognize that, as seen in this figure, the PR interval can be very long and exceed the PP interval, the total CL, during Wenckebach periodicity, in which case the atrial impulse conducted to the ventricles is not represented by the P wave that immediately precedes the QRS complex. That is, a sinus impulse, and P wave, will be fired, while the previous impulse is still in its way to the ventricles. Thus, another P wave will appear in ECG before the QRS of the delayed impulse is seen. In this way, the QRS is not related to the immediately preceding P wave, but to the P wave before it. Atypical Wenckebach patterns. Unfortunately, less than 50% of Wenckebach AV block cases follow the typical pattern, which adds to the difficulty in diagnosis. Atypical patterns are more likely found with longer Wenckebach periods, more than 6 to 5. Many atypical features are described. 1. In patients with dual AV node physiology, about 25% of people, Wenckebach cycles are almost always atypical. The greatest increment in PR interval occurs with block in the fast pathway, whichever beat this may be, not necessarily between the first two beats. 2. Very little change in PR duration may occur, which may be overlooked. 3. The increment may increase for the PR interval of the last conducted beat. 4. PR interval can shorten and then lengthen again in the middle of a Wenckebach sequence. Site of Wenckebach block. Wenckebach block is almost always within the AV node, and rarely in the His-Purkinje system. AV node involvement is suggested by normal QRS duration. His-Purkinje system involvement is suggested, but not proved, by wide QRS duration, or short baseline PR interval indicating healthy AV node. Type 2 second degree AV block. In Mobitz type 2, or simply type 2, second degree AV block, there is sudden failure of conduction of the P wave, followed by a pause, typically having the following two characteristics. 1. The PR intervals of all conducted P waves are constant, normal, or prolonged, including the PR before and after the pause. 2. The pause equals twice the PP interval. Type 2 second degree AV block, the PR intervals of all conducted P waves are constant, normal, or prolonged, including the PR before and after the pause, and the pause equals twice the PP interval. Site of type 2 second degree AV block is almost always below the AV node, 30% in the His bundle, and 70% in the bundle branches. 2:1 AV block. 2:1 AVB means that only alternate beats are conducted, resulting in 2:1 AV, PQRS, conduction ratio. The PR interval is constant for the conducted beats, provided that the atrial rhythm is regular. What about 2:1 AVB, is it type 1 or type 2, second-degree avenue block? 2:1 AV block cannot be classified as type 1 or type 2. Both type 1 and type 2 can progress to 2:1 AV block, and 2:1 AV block can regress to either type 1 or type 2. To understand how type 1 block can progress to 2:1 block, just remember that in type 1, the P-wave number in each Wenckebach period always exceeds the QRS number by 1, the blocked beat in each period. Thus, the conduction ratio is, for example, 6:5, 5:4, 4:3, and so on. With progression of disease, a conduction ratio, for example, of 6:5 will progress to 5:4, then 4:3, then 3:2, then 2:1. High-grade second-degree AV block. High-grade, also called advanced, second-degree AV block is defined as failure of conduction of 2 or more consecutive P waves, when AV synchrony is otherwise maintained, that is, the PR of conducted beats is fixed. Advanced second-degree AV block is seen in this figure. Only 3 P waves are conducted, arrows, having narrow QRS complexes. All other P waves are blocked with ventricular escape beats having wide QRS complexes. Third degree, complete, AV block. AV block is termed complete when all P waves fail to conduct. ECG features of complete AV block. 1. Completely dissociated P waves and QRS complexes, each firing at its own pacemaker rate, with continuously changing PR relationship, as the P waves march through all phases of the ventricular cycle. A difficult situation may occur in which the rate of both supraventricular and ventricular foci may be very close, and AV dissociation may be overlooked, a condition called isarrhythmic dissociation. 2. Regular ventricular rhythm. 3. The atrial rate is always faster than the ventricular rate. Reading ECG in complete AVB. Recognize AV dissociation. Calculate the atrial rate. Calculate the ventricular rate. In congenital complete AV block, the ventricular rate is relatively faster than in the acquired form. QRS width, either narrow, if the escape rhythm is above the His bundle bifurcation, or wide if below that bifurcation. QRS pattern, right BBB pattern is seen in case of a left ventricular escape rhythm, but left BBB in case of a right ventricular escape rhythm. Other ECG changes may point to the etiology. This is a schematic shows complete AV block. Notice the completely dissociated P waves and QRS complexes. The escape rhythm is below the His bundle bifurcation, with wide QRS complexes. Paroxysmal AV block. Paroxysmal, also called intermittent, AV block is usually induced and terminated by premature atrial or ventricular beats, and commonly associated with prolonged ventricular asystole. Its site is mostly intra-His disease. The electrophysiological mechanism is probably phase 4, bradycardia-dependent, block. Thank you.